No. Good morning, everyone. I'm Eileen Robinson. I'm the program manager for the research program on cognition and neuromodulation-based interventions. Welcome. We're so happy you're here today. I'd like to introduce Dr. Hampstead. He is the Stanley Barrett Professor of Psychology, Department of Psychiatry at the University of Michigan. He's also the co-clinical core leader. He is the clinical core leader and the co-neuroimaging core leader at the Michigan Alzheimer's Disease Research Center. He is also a staff psychologist at the VA here in Ann Arbor, Michigan, and he is the director of the research program on cognition and neuromodulation-based interventions.
First, thank you all for being here. I know we have a lot of people online actually viewing in. So we have over 370 people registered. I think last I heard it was 15 or 16 different countries. So in addition to the in-person, we do have a big online component. Well, thank you very much. I'm really excited about today. This is something that we've talked about for a long time. The speakers that we have here today are those that I really admire and that have played a big role in my career and that are really leaders in this area. So again, I really appreciate everybody being here. We've flown, the folks have managed to make their way from Australia, from Canada, from Europe, Netherlands, as well as then throughout the US. So Brazil, sorry. So really very excited to have everybody here. I'm going to first run through the lineup here. We have two speakers from the UK who have sent in video-based recordings, but they will be joining us live for questions and answers. So we'll have kind of a mixture of in-person Q&A as well as online. So those attending virtually, please feel free to put your questions in the Q&A slot. Stephanie Nava will be addressing those with us. And also don't forget to, for those who need them or will benefit from them, don't forget to scan the QR codes and claim your CE credits. Huge thank you. I think I've grown to appreciate the team even more, seeing all of the moving parts and seeing all the late nights that went into making this possible. So thank you all. Many more have contributed. We have a lot of volunteers, as you can see. So wonderful, wonderful team. So with that, I want to jump in and just focus on kind of the bigger picture and maybe some key points that may resonate throughout some of the remaining talks. I want to ensure everybody have no conflicts of interest that are relevant here. I want to acknowledge the funding agencies. So the Department of Veteran Affairs has funded me for 15, 16, 17 years. National Institute on Aging, and we mentioned that this is possible through the R35 grant from the National Institute on Aging, and also want to acknowledge the Michigan Alzheimer's Disease Research Center, who is a huge partner with our program and really has a wonderful synergistic relationship. So there's some take-home messages and key questions that I thought that we could start off, just kind of setting the stage, I think, overall for today in general. You'll hear about multiple approaches for enhancing and maintaining cognitive functioning. We refer to these grossly as cognition-oriented treatments, or COTs. So when you see that acronym, that's what we're referring to. But when we think about how these techniques work, they seem to differ in their cognitive mechanisms of action. And I'll show you some imaging data, and I know others have imaging-related data that also support this. And I think this is important for us to think about within the context of neurobiology and where the diseases that we deal with are targeting. And should we select techniques that engage those areas or avoid those areas, or some combination of both? So I think that's a bigger picture issue that hopefully folks can think about as we move forward. And I think that, in the literature, we often see meta-analyses and systematic reviews that kind of collapse all these techniques together. That may be okay, but it's also like collapsing multiple classes of medications together and determining one omnibus effect. And so I think there's a lot of nuance that goes in that I think we need as a field to do a much better job of sorting through. and really understanding the optimal conditions that we use these. I'll very briefly, as time allows, touch on dose and outcome measures. I know some of the other speakers will as well. And with that, I want to start off, again, putting things in the broader perspective. So the aging dementia continuum, because it is a continuum, even though diagnostically we look at these discrete categories, we know that there's no magic demarcation between quote unquote normal cognition and MCI or MCI and dementia. It's really a continuum. When we think about applying interventions and COTs to this population, we have to keep in mind that this is different than our traditional stroke or traumatic brain injury, where as this line kind of represents, you can see that in this case, people might be going along just fine. There's a sudden insult that causes a loss of cognition. In this case, let's say it's memory. And then we would expect in those populations some degree of spontaneous improvement over time. So when we intervene, we're working with an upward trajectory. We may never get the person back to baseline, but at least we know there's an upward trajectory that short of an additional insult, there's not going to be additional decline. When we think about neurodegenerative diseases, we're dealing with the opposite slope. And so when we think about that process, we know that early on, we may be able to maintain or even improve functioning because we have more cognitive and hence neural resources. Whereas later in the disease, maybe we just want to choose some very specific areas to intervene that are relevant to the person's everyday life and then help them live as independently and as fully as they possibly can. Because we know we're going to have fewer neuronal and cognitive resources. And I think one of the big questions that we discussed a little bit today as a group was, what is our goal? Is it to enhance functioning or is it to maintain functioning? And I think both of those can easily be considered wins. But I think a lot of times we're stuck in this mindset that, well, we got to show significant improvement, when I think some of the data that many folks will show you today suggests that maintenance is entirely possible. It's just that our studies are not geared toward that. And I think we have to be cognizant of that fact. So when we think about Alzheimer's disease, and I know we have Alzheimer's and related dementias, but I'll just use Alzheimer's as a model here. What's especially intriguing is that we now have a good array of biomarkers that we can use. Blood-based biomarkers are easily on the horizon. And so this might change the landscape. Maybe it does, maybe it doesn't, but I think we need to be aware of this and we need to think about whether or not we need to integrate these biomarkers. Because as this kind of classic jack-it-all curve, which has been modified, but I use this one just for the sake of simplicity, we know that the toxic proteins, in this case amyloid and tau, accumulate years and years before cognitive symptoms emerge. So that gives us a wonderful window to intervene and, again, maintain functioning. Once we get into the MCI or dementia phase, maybe we need to shift gears a little bit. We also know that, again, these biomarkers enable this type of characterization using the ATN framework. I know there's a lot of debate about this framework, but I think for our purposes, this is kind of useful, and especially as we think about, again, some of these blood-based biomarkers that certainly will eventually be integrated into clinics. And once we get people with a given profile, do we need to preemptively, perhaps, apply some of these techniques that, again, help maintain functioning? The role of these cognition-oriented treatments and other non-pharmacologic interventions is even more highlighted by the recent disease-modifying agents that have hit the news so much recently, where in this case, lecanemab has shown what appears to be a really beautiful clearing of the toxic amyloid. But when we look at the cognitive or the everyday functioning data, across measures, you basically see this curve. Great, it's slowing the disease, but it's not holding people stable, it's not enhancing functioning. And I think this is a really important point that, great, if we can get the disease, at least the Alzheimer's related toxic proteins off the table, well, then that might give us, again, a little bit more window to try and intervene and maintain functioning at a given level. So I think that, again, we've traditionally viewed medications or non-pharm interventions where I think probably we need to shift and view them in synergism just as we would with a blood pressure medication, modifying diet and adding exercise to control blood pressure. So again, a little bit more about some of the techniques you'll hear about. This is from Dr. Bacher-Fuchs, the Cochrane Review. I like this table. It provides a nice definition of things like cognitive training, which is more individualized. It can be group or individual, but it typically focuses on impaired abilities and provides training specific to those impaired abilities. Whereas cognitive rehabilitation and true cognitive rehabilitation that I know Dr. Stringer and Dr. Claire will talk about a little bit later today focuses on what's important to the patient or the participant. And so there are individual goals, and you can take any of these approaches that we talk about today in order to accomplish those goals. It doesn't matter how you get there as long as you get there. Whereas then things like cognitive stimulation, we're probably not going to talk a whole lot about today because that's much more typically for moderate to severe disease stage and as a way to try and, as the name implies, engage people cognitively. So with that context in mind, probably the best known cognitive training study has been the ACTIVE trial. And this was a large study, a randomized trial of over 2,800 older adults. Training was provided in a small group format for 10 sessions over the course of about 5 to 6 weeks. And these data that I'll show you are from the 10-year follow-up. They're now 20-year follow-up data that I know they've completed data collection and are working on the analysis. So what this study did was randomize people to either no contact control group or one of 3 active cognitive training conditions. So the processing speed training using a useful field of view approach, a reasoning training, or a mnemonic strategy training. And the interesting thing here is that each of these 3, as you'll see in these graphs, each of these 3 approaches was highly effective. So the processing speed training, you can see huge benefits in processing speed as measured in this study that persist over a long period of time. Likewise for reasoning training, wonderful effects on reasoning training. Likewise for memory training, wonderful effects on memory performance. Now the 10-year data, I do want to point out that this, the 10-year data said that there was no significant benefit of memory training. But I think it's important for us to look at the curves here because what strikes me is that the control group deviates from any other group. This slope of the control group is now different because for all the other years, it was right in between the other groups. If you were to compare strategy training with the other 2 active interventions, there's still this, it looks to me, a pretty darn good effect. It's just that the control group deviated and it's the frame of reference that was used statistically. So I think there are a couple of things here that I want to point out. One, this clearly shows that when we target a cognitive domain, cognitive ability, we can enhance it. The other thing is that there isn't transfer between these approaches. That's long been viewed as a limitation in this field. To me, it's just a condition of use. If one of our geriatricians prescribes a blood pressure medication, but your cholesterol doesn't change, does that mean that the blood pressure medication failed? No, it means that now you need a statin. So I think we need to mentally shift, and that's where, again, the technique is important. So not to belabor the point, but in some of these meta-analyses and Cochrane reviews, again, cognitive training has been shown to be beneficial in both cognitive impairment and in those with dementia. So I think, though, I've talked mentioned a couple of different times the different approaches and how they matter. And this comes from a review that we put out, gosh, almost a decade ago, but I think it's still quite relevant because what we try to do is group these different approaches as they apply to memory and group them based on their presumed cognitive mechanism of action. So over on the left, you can see rehearsal-based approaches, and I'll walk through each of these very briefly, and then I'll give you some examples of the differences between them. So the rehearsal-based approaches, as the name implies, practice makes perfect. You do things over and over, you get better at them, right? We all use this all the time. So we know some of the pros, this can be very, and as we think about applying this to memory, we know that these techniques can be very effective for teaching specific content. For example, the name of new church member. And they can be very efficient. So we have all these computerized cognitive training programs now. But the cons, they're really not likely to generalize. So You may learn person A, but if you have new person B that joins your church, you're going to have to repeat this exact training to learn that person's name. So again, there are a lot of different cognitive training approaches out there. I'm not going to go into depth, but if we think about dose, this is one critical element that a lot of the studies that have used these different approaches have given a huge dose of training. 20 to 60 minutes per day for multiple weeks. So again, if we think about some of these other techniques that you'll hear about today that are showing nice benefits with pretty short intervention periods, what happens if we standardize the dose across these different studies? External aids, I believe Dr. Smith will talk a little bit more about that, probably Dr. Turner as well. I'm not going to talk too much about these. We know that they can be effective. Cell phones, calendars, how many of us live off of our cell phone or off of our calendar? I know I do. So that it's no surprise that if we can get our patients to adopt these into their daily life, that they'll benefit. But some of the things that we've heard from our patients is that they feel self-conscious having a notebook where they record information. Some do, some don't. Some may be complex. I think phones have come a long way. There are phones that are made specifically for older adults that seem to be a little bit addressing that technology barrier. And I think sometimes these techniques may not be appropriate. So try and imagine trying to record the names of people you meet today and say in 5 years, if we're fortunate enough to do this again, trying to flip back through the notebooks to find those names, right? Pretty unrealistic. Now, internal strategies, mnemonic strategies are again, I have a bias that I think early on in the MCI to healthy cognitively intact adults, I think that's a very effective place to apply these. And so we'll talk a little bit more. I like these because they provide a rule that if once the patient learns, they can independently apply these. We know that it increases the depth of processing and it helps to enhance structure. And I think some of our imaging data certainly support that we're helping the brain optimize functioning when people learn to use these, but they're really effortful and they can be time consuming. So if we think about a situation where people may have some time constraints, or if we think about the bradyphrenia or the slow processing speed that many of our patients have, gosh, maybe it's not the right choice for those particular people. It may be more complex than the task demands. So I can make a great list of things I need to pick up from the grocery store, but I know if I forget to pick those up on the way home, I got to go back to the grocery store. So I just want to text with them because then I can check off and have that written evidence that I didn't screw up. So one of the things that we've tried to do is really create ecologically relevant paradigms to train people on so they can see how this applies in their everyday life. And I think one of the critiques of cognitive training is that you're often training the task. But I have to say, gosh, if we're focusing on an ecologically relevant behavior that's problematic to the patients, so what? That's great, right? That's a win. So I'm going to give you an example of how we've used these paradigms to kind of understand the neurobiology, the disease-related changes, as well as the intervention-related changes. So in this case, we'll focus on this object location association paradigm. So this is nice because what we do, we show people an object, in this case a ring, and then we show the location of the object within a realistic enough looking room. Back in the day when I designed these, I'm certainly no interior designer. So you get the point, this is a ridiculously large vacuum. Okay. So people are just instructed to remember where the ring belongs. Now this builds on, Dr. Kessels and colleagues had a really wonderful model built on Michigan and underleaders ventral versus dorsal visual stream. And we've validated this using this particular paradigm, but the ventral visual stream we know is involved in the processing of what it is you're trying to remember. In this case, say the ring. We also know that it engages the dorsal visual stream, the where pathway. Where is this object located? What this paper from Postman and Dr. Kessels showed that really you need to engage this frontal parietal cognitive control working memory network to hold the what and where in mind until it's bound into a memory trace by the hippocampus and other medial temporal lobe structures. So this model fits nicely, and when we compared MCI to cognitively intact older adults, no surprise, MCI patients showed significant reductions in the hippocampal activity, right? Wonderful to see, but I would have been concerned if we didn't see that, because that's what characterizes amnestic MCI, memory deficits. What was more interesting were the neocortical differences, where healthy cognitively intact older adults showed greater frontal parietal activation, among other areas. And when we looked at the effective connectivity using greater causality analysis, what that basically does is look at these activations in the brain areas in the same regions for the cognitively intact older adults and the patients with MCI. And we looked at how these areas are communicating. And what we saw was that there were three primary drivers of activation, areas that really influence the activation in other brain areas. And in the healthy older adults, each of these three hubs that you can see these lines emanating from are in that left frontal parietal cognitive control network. Wonderful, right? Now, I don't have to say another word. You know that the MCI are different. This one primary hub that you see in the MCI is now the right frontal eye field. What do the right frontal eye fields do? Attentional saccade. So basically, ooh, something shiny, drawing your attention away. So how we interpreted this was that patients had a reduced top-down control during memory encoding. Okay, cool. If that's the case, why don't we go ahead and provide some tools to try and increase their top-down control? Well, then that's where this line of investigation has come from. So we have a number of studies that we've done now where we've taken these mnemonic strategies because, as I mentioned, they can engage top-down cognitive control, and we've compared them with very tightly matched rehearsal-based approaches. So exact same number of trials, same patient experience, only difference is how they're learning this information. In this case, we used spaced retrieval. And so this is a paper we just put out on Alzheimer's and dementia. Using this object location and the mnemonic strategy training went along these lines. Identify a salient feature in the environment. In this case, the sinks. So we know that the ring is near the sinks. Then you develop a verbally based reason that links the feature with the item that you're trying to remember. And this really comes from Dr. Sterner's Eon Mem program that we have adapted a little bit to try and make it fit across multiple types of associative memory. So as you can see, this reason is not very complex, right? It's not rocket science, but it does that trick of getting the person to think about, well, gosh, how could these two things be related? It's a scaffold, because we know that binding, that associative binding is not happening in these patients. The spaced retrieval, exact same number of trials per item. And what we did was to systematically increase to double the delay. So we went from 0 second delay to 1 second to 2 seconds to 4, up to 128 seconds that people were just sitting there staring at a blank screen. Very, very tightly matched condition. What we saw when we looked at the cognitive data, how well did people remember information? Well, the strategy group, you can see that both techniques were quite effective in training new information. So these are patients with memory deficits. These data were, the post data here, were collected 2 days after the final learning session. So we improved their retention of that information over the course of at least a couple of days. But the magnitude is so much greater for those in the mnemonic strategy training, and this benefit persists at 2 months. Well, the interesting thing that we saw was that the patients in the mnemonic strategy training group showed an increase in frontal, especially in the IFG here, activation, and increased hippocampal activation, which replicated our earlier findings. Alex Jordan, one of our faculty, ran some connectivity analyses during the test using the hippocampus. And as you can see, the hippocampus was now communicating more with other brain areas after the strategy training. Well, what happened in the spaced retrieval group? Again, same number of trials. We saw reduced activation. Well, what does reduced activation mean? Well, we interpreted it as kind of the repetition suppression effects, where the more times you see things, the more efficient you process them. And importantly, there were no hippocampal changes in this group. So here's a network-wide, I don't want you to spend too much time, but I do want to focus on one thing. You can see that in the strategy training group, there was a lot of increased communication between different brain networks, right? That's not the case in the spaced retrieval. Again, this highlights those univariate analyses I just showed you, where there's a lot more reduced communication between brain areas, much more efficient processing. So, I think this is, again, really highlighting that the technique matters. not only cognitively, but also from a neuroanatomic standpoint. So we've shown this across multiple randomized trials, including Dr. Simone's trial that was done in a Brazilian population that took these same techniques and compared them with an active educational control group. So, I think that we're kind of onto something. And we just finished a trial that combined these strategy training with a type of non-invasive brain stimulation, transcranial direct current stimulation. So we're currently analyzing those findings. In just a couple of minutes I have left, I do want to touch a little bit on dosing and how should we measure this. This is a graph from, and I know it might be a little bit hard to read here in person, hopefully online it's a little bit better, but this comes from our review that, again, just to give a sense, the most common way that people have measured dose is in the number of hours. I have to wonder, is hours really the best metric? Is each hour comparable? Right? So you've all worked with patients and you know that 1 hour is not the same as the next hour, let alone in between individuals. So should we embrace some type of trial-based or skill mastery approach? I think we have to consider the billing ramifications, and this gets more into policy, but I wanted to throw this out there. Also, what are our outcome measures? What are the methods that we have? And so again, we walked through some pros and cons. And at the time we summarized, and this is intentionally obnoxious because we wanted to show how little agreement there is on outcome measures in this area. And I think this problem still persists. So we provided a potential model to move this area forward. And I want to leave a couple minutes for questions anyway. So again, I'll just hit on some of these key points that I think we are ideally positioned to inform the care and to interact with the disease modifying agents. And with that, I want to acknowledge the fantastic team that I get to work with every day and thank all of you for being here. So I think we have just a couple of minutes for questions. Okay. Any questions?
So when we worked together, we did work together on the echolocation paradigm training, so to say, in patients that I'm seeing because of amnesia patients. And then we found that these strategies were too complex for the patient, which did not surprise me. Can you elaborate a little bit, because you talked about the AD spectrum, so we have MCI, early AD, Alzheimer's dementia, and then the later stages. What's your experience about the complexity of such interval-based strategies in the specific moment in the disease stage of progress? It's difficult to determine individually where it does no longer work.
Yeah, that's a great question, and I agree. It was interesting that we didn't really see any benefit in those Korsakoff patients. I think you touched on a really important point of that stage of the disease. Where do they fall in that kind of continuum between normal, quote unquote, and dementia? And I think what we've seen is that probably, and I don't know that we have any hard and fast cutoffs. In some of our smaller trials, we did see relationships between executive functioning and the benefit that people would show from the strategy. I don't know if it will persist in the current data the study we just finished that was much larger. But my subjective feeling, and I'd love to hear the other presenters talk about this, is that once we start to really get closer and closer to the dementia side of MCI, and I don't know how to define that, but as additional cognitive domains are really starting to take a hit, that's probably when I would personally shift over to a reversal-based or an external aid-based approach. Whereas if we can catch people earlier, and again, in the cognitive intact, we have biomarkers on folks, I think that's a great time to jump in, to intervene, teach them these strategies that can probably then buffer against additional decline. So great question.